Hello, I am LJ Tan. I'm the Chief Strategy Officer for the Immunization Action Coalition, and I would like to thank the Kinetic Pharmacists Association for inviting me to provide you this presentation on addressing vaccine confidence. Thank you very much for this opportunity, and I hope that this presentation is of use to all of you. A couple quick uh, items just to disclaim that anything I present today is my expert opinion and does not necessarily reflect the opinions of the Immunization Action Coalition, which is my employer, or the National Adult and Influenza Immunization Summit that I co-chair with the CDC and the Office for Infectious Disease Policy at HHS. The program objectives today, at the end of today, you should be able to describe the evolution of vaccine confidence and vaccine hesitancy in the United States, discuss the importance of risk management and risk communications in vaccine confidence, and detail 3 interventions for discussing confidence with your patients. And so my outline is simply this. I'm going to talk a little bit about vaccine confidence and provide a little history as to why we have this problem. I also would then talk about some of the interventions that we can think about with addressing patients' concerns, how to talk to your patients on vaccines, and some issues with some knowledge on motivational interviewing, specifically mentioning the 3Cs toolkit that comes out of the Unity Consortium. So what exactly is vaccine confidence? And this is a definition that is pulled out from the work that's been done by the National Vaccine Advisory Committee. Vaccine confidence refers to the trust that parents or healthcare providers have in 3 things. Firstly, the recommended immunizations themselves, the provider, that would be you all, who are administering vaccines, as well as the process that leads to vaccine licensure and the recommendation vaccine schedule that all of us follows. What these 3 dimensions of vaccine confidence implies is that the parents as well as the patients are aware of the recommended vaccinations and have some knowledge of how vaccination recommendations are made, and that vaccine acceptance is interrelated, right? It is a matter of vaccine confidence. It is also a matter of the decision and the outcome as well. So just a reminder, I think I'm preaching to the choir here, is that we vaccinate for very good reasons, right? Vaccine good, disease is bad. And here in this table, I show you some of the diseases that have been eliminated from the United States because of vaccination. So you look at smallpox, polio, measles, rubella. And of course, we do have outbreaks of measles, but they tend to be because of imported cases being the start, and so hopefully we will be able to get a lot of those outbreaks under control again soon. But again, vaccines good, disease bad. And this next graph from the Journal of American Medical Association, this is a fairly old slide, but I like to use it because it shows us the impact of vaccination on disease and mortality and morbidity in the United States. On the left-hand side of this graph, you see the diseases, and in the middle column, under pre-vaccine, you will see the number of cases and deaths that we had as a result of these vaccine-preventable diseases. And then you can see on the right-hand side, which I've circled in red, all of the reductions in deaths as well as cases as a result of the immunization program in the United States. And this immunization program in the United States has obviously led to us becoming a victim of our own success. So, good success in this pediatric immunization programs have led to these incredibly low levels that you just saw of vaccine preventable diseases. And when you have no disease, the perception of risk and the acceptance of risk changes. And this concept was first introduced by Dr. Chen a couple of decades ago now. And it was recently republished, obviously, in Vaccine in the reference you see at the bottom. And this is the diagram that he talks about a lot and that a lot of us begun using. So if you see incidence of disease on the left-hand side and the maturity of the immunization program on the x-axis, what you see in the dotted line, obviously, is vaccination coverage. And what you see in the solid line is a disease. And as you can see on the bottom in the multiple little dotted lines is the adverse events that might be associated with vaccine. So as you can see, you've got disease at the very beginning, you've got no vaccine, and as vaccine becomes approved and utilized, the vaccine coverage begins to go up, and as a result of the vaccine coverage going up, you see the disease beginning to go down. And as the disease goes down, there comes a point at point number 3 where you have a loss in confidence. And that's because you no longer see the disease. You see high coverage rates, but as you can see from the dotted lines at the bottom, the adverse events have gone up. And so those become the focus of the attention rather than the fact that we have no disease. And then because of the added attention to adverse events and the fears that can be generated as a result of that, you see the decline in coverage rates and you see an outbreak as a result of that decline in coverage rates, which is what we've been seeing a little bit with measles. With the outbreak comes a resumption in confidence again in the vaccines. And again, the vaccine coverage just goes back up and the outbreak gets managed and disease levels go back down again. And hopefully at some point we reach eradication, kind of like what we did with smallpox. And after eradication, you can stop vaccinating. But there clearly, as you can see from the previous point graph, that there is a tipping point when the patient concerns about those adverse events that we're seeing because of vaccination outweigh what they perceive as the benefits from those vaccines. And ultimately, those concerns will lead to public detriment. And unfortunately, as you now know, that time is now. We've got data that shows 46% of adults are still unsure that vaccines do not cause autism. 1 in 4 parents believe that vaccines can cause autism. 1 in 6 caregivers of children with autistic spectral disease believe that vaccines are the cause. So I think we are at this point where these concerns about potential adverse events, whether or not they are actually related to the vaccination, overcome and overwhelm what are the actual benefits that we see from vaccines. So as the attention shifts to risk, you can see the same thing happen in the social media, right? And so these are some of the anti-vaccine websites that are all over the internet. So when your parents and your patients are Googling vaccine safety, these are some of the networks that they're picking up, very official sounding websites that give legitimacy to their misinformation regarding vaccines. Children Defense, Health Defense, Informed Consent Action Network, National Vaccine Information Center, and so on and so forth. And unfortunately, there is public and individual harm when we do not have our high vaccination coverage rates. And as we saw in that graph from Dr. Chen, we know that there will be outbreaks. And as we saw in measles in the United States, measles was declared eliminated in the US in 2000. Measles cases continue to be imported into the US, and the 2014-2015 outbreak was traced to a tourist who came in unvaccinated with measles into a major theme park in California. Many of you know what that theme park was, and that outbreak spread from California to at least 7 other states. Just a reminder, that outbreak resulted in California passing legislation to eliminate the philosophical exemption against vaccination because there was such a major outbreak. And to also remind us all that 57% of those cases in California were actually in adults. So adults are just as susceptible to these outbreaks as kids, and so something to keep in mind. And what is clear that because of the importance of these susceptible clusters, so people who have chosen to not get vaccinated, they become the focus points for these outbreaks, get an anchor and spread. And so that's why California eliminated the philosophical exemption, and it's an attempt to eliminate these clusters of susceptible people, and the knowledge of the fact that this is a problem, that there is public and individual harm, was picked up by the media, and we saw a radical media shift as a result of the outbreaks. And a lot of the public opinion moved towards, fighting the foolish, as you see here, tackling the vaccination crisis, understanding the fact that we do need to have vaccination to protect our public health. And of course, as the landscape of public opinion shifted against the people who were against vaccines, we saw, we began to worry also about these clusters of vulnerability, right? So just to remind us all that these clusters of vulnerability existed and was highlighted by the measles outbreak, right? So as the media began to point out these clusters of vulnerability and the fact that we needed the public health protection from vaccines, you can see that the anti-vaccine lobby also began to change tact. So this idea about vaccines causing autism, so on and so forth, a lot of that began to shift. And the current battle that we're facing with our anti-vaccine activity is about the fact that they've moved towards this idea of you can't mandate vaccination. You need to have informed consent. Personal autonomy is very important. And of course, as you all saw, a lot of the anti-vaccine forces kind of allied themselves with the anti-masking forces that we have in our current COVID-19 pandemic, because of the fact that there's this alignment of it's my personal autonomy. I don't have to wear a mask. It's the same thing. I don't have to get vaccinated. Personal autonomy. So that appears to be the latest tactic for the anti-vaccination forces. So that being said, I want to spend a few slides, and I'm not going to spend a lot of time here, but you will be able to see this at your own time to reassure you, as well as all of your patients, that vaccines in the United States are very, very safe. We have in the US probably the best vaccine safety process in the world. And I'm going to run through some slides just to show you the overwhelming amount of safety that we do have. The licensure process, as many of you have now seen this undergo a microscope because of the fact that we're trying to accelerate that process with the COVID-19 vaccine. But it generally is a lengthy, rigorous process through the FDA. We have federal advisory committees that many of you are aware of, starting first and foremost with the Advisory Committee for Immunization Practices, the ACIP or ACIP, that produces recommendations on how to use an approved vaccine or licensed vaccine by examining published and unpublished data on safety, efficacy, effectiveness, and cost effectiveness. We have the National Vaccine Advisory Committee that does policy recommendations to the federal government. And we also have the Advisory Commission on Childhood Vaccines, which gives advice to the DHHS on issues regarding vaccine injury compensation. Just to remind everybody that once a vaccine gets approved and used in the public, it doesn't stop there. There's a lot of vaccine surveillance mechanisms out there to help us track vaccines, how they're being used, as well as track the adverse events. Of course, manufacturers continue under the licensure process to do what we call phase 4 trials, which means further up following trials to make sure that the vaccine continues to be shown to be safe and effective. So these are some of the surveillance mechanisms out there. We have the Vaccine Adverse Reporting System that you all know that, VAERS. Just to remind everybody that this is a passive reporting system. Anybody can report to VAERS. And so an adverse event is only defined by the fact that it was temporally associated with the vaccination. It was not necessarily causally associated. But it's very important because it's like the canary in the coal mine. It allows us to generate hypotheses for potential associations between adverse events and vaccines. And then we can actually test those hypotheses through some other surveillance mechanisms, such as our Vaccine Safety Data Link project. This is a large collaboration that actually allows us to test whether whether an alleged adverse event temporally associated with vaccination truly turns out to be an actual adverse event. So we've got the Vaccine Safety Data Link project. We have the VSD Rapid Cycle Analysis. We have the Clinical Immunization Safety Assessment Centers. And of course, we have the Institute of Medicine. All of those are there to help us actually evaluate causality from our surveillance data. So again, not to put all this on you to remember, but to just highlight how safe our vaccines are because of all these surveillance processes we have in place following licensure of the vaccine. So I hopefully have convinced you that vaccines are safe, but again, to remind that nothing in life is risk-free, right? So if you take a look at this table, RotaShield, which as you all remember back in 1999 was withdrawn by the ACIP, the recommendation was withdrawn by the ACIP because of documented intussusception, which is a twisting of the intestine. The frequency of that risk was one case in 10,000 people who received vaccines. There's argument that if rotavirus was a major killer of children in your country, that might have been a risk that you were willing to accept. But in the United States, it was not. You take a look at oral polio with vaccine-associated paralytic polio, 1 in 2.4 million doses, whole cell pertussis with acute encephalopathy. It was actually no frequency in, it's very, very low. one in maybe 10.5 million doses. But these risks that we know exist have to be represented accurately as you talk to your patients. So you need to use the vaccine information statements that you have, and you have to be truthful when you communicate about vaccines. For example, you need to tell them that there's nothing that's risk-free and that billions of vaccines, however, are given in the world annually without any problems. So truth, is extremely important. But when you remember, so I'm going to give you some truths when it comes to risk management and risk communications here now. So one of the truths that we want to think about is when you are evaluating risk, emotions count. So when we sit here in our academic high horses or ivory towers and talk about, well, the science shows and the science shows, we have to remember that a lot of people base their judgments of an activity not on just how they think about it, but also about how they feel about it, right? So if feelings towards an activity are favorable, you tend to underestimate that risk. But if feelings toward an activity are not favorable, that risk is perceived to be very, very high. So for example, I am not favorable to jumping off a cliff with a rope tied to my ankles. And so as a result, I perceive the risk of bungee jumping to be extraordinarily high. Whereas many people would tell me, actually, I'm overestimating that risk. But there's obviously strong negative correlation between people's judgments of the risk and the benefit of the activity. So for me, bungee jumping is extremely high risk and therefore of low benefit. And remember, it is very hard to communicate risk. And it is essential that we are able to, in our conversations with our patients, manage their perceived risks as well. Risk tolerance will increase with a more urgent need. So, for example, if you have migraine headaches, you are willing to accept the risk of taking Tylenol with codeine because of the fact that the pain management is something that helps you, right? And so you take that risk. But you have to remember that when we give vaccines, we're giving them to healthy people, right? These are preventative interventions. And as a result, when you give something to healthy people, your risk tolerance decreases. You're less willing to accept that risk because you're not sick. And then remember that the perceived chance that something will happen correlates with the ease with which you remember it, right? So we need to make sure that if people will say, hey, I remember this better because of the fact that I remember it better, therefore I believe that it's likely to happen. So we need to be very clear and give facts regarding to vaccine safety to correct these faulty recalls or these faulty associations. Just because you remember it better or with ease doesn't mean that it actually is a causal association. Finally, remember that trust will impact how people perceive risk. When you receive something from someone that you trust, you're going to believe it far better than information from untrusted sources, which is why there's a lot of work undergoing to undermine your authority as a healthcare provider by the anti-vaccine forces. So something is perceived as more risky if people think that it's coming from a source that's untrustworthy. Hence, you saw terminology like CDC is conspiring to poison you, for example, right? And then on the new media platform out there in social network world, anyone can be perceived as an expert. So you need to make sure that you know the sources of your information. So this cartoon I think is very funny. A dog is in front of the computer and the dog says, on the internet, nobody knows you're a dog. So know the source of your information. If you do a search on Google, you will pull up a lot of those anti-vaccine websites that I showed you earlier. And so you want to know how to identify these credible websites, as you can see here. Our website at IAC gives you a lot of information on this, so please take a look, but also recognize there are ways to identify whether a website is credible. Here are some. I'm not going to spend a lot of time running through these, but these are all credible websites that you can go to and receive science-based, evidence-based information on vaccines. Finally, with regards to risk communication and risk management, know that known risk overcomes unknown risk. So if you know a patient knows their risk and you've communicated that risk, it's more likely that the patient will accept that risk than if the patient has unknown risk. I don't know what's going to happen. That's a huge fear driver. So we all need to shed light on the unknown risk by making it known, actively communicating the facts that we do know about vaccines and their safety, right? Those all that vaccine safety things I showed you earlier, licensure, safe and actual safety issues that are associated with the vaccine. There's something called omission bias that I think we all have to remember, which means that basically passive blame is easier to accept. It is easier for me to accept a bad result if it came about due to my not actively having done something, right? So if something bad happens to me, but I didn't actively pursue an action that resulted in it, I can accept that better. But if I actively pursued something and then something bad happened, I feel worse about it. So I think we need to recognize that, and we need to educate all our patients that nothing is risk-free, and that a decision to not vaccinate is actually an active decision to become susceptible to disease. So not vaccinating and not getting an adverse event is actually an active choice to expose yourself to disease. So I think that's something that we need to kind of keep reminding our patients. Here's a wonderful quote from Benjamin Franklin on omission bias. I think it is important to recognize that even back then, vaccine safety, vaccine confidence were issues they were wrestling with. And he says, in 1736, I lost one of my sons, a fine boy of 4 years old, by the smallpox, taken in the common way. I long regretted bitterly, and still regret, that I had not given it to him by inoculation. This I mention for the sake of parents who omit that operation on the supposition that they should never forgive themselves if a child died under it. My example showing that the regret may be the same either way, and that therefore the safer should be chosen. So change the perception, right? Change that risk perception. The context in which a decision that the patient is making affects that decision. So change that perception. Do you want your child to actually become sick? Discuss the risk in terms of the negative impact of the disease on the parents, on the patients, and the child of the parents, obviously. Some things that you're going to have to remember when you're talking to your patients is that it is you got to realize that patients and parents have poor understanding of vaccine science, unlike healthcare providers. But we want to acknowledge that all patients want to do what is right, and a parent especially wants to do what is best for their children. But there are very strong anti-vaccine forces that are pulling on them and have their attention. So as healthcare providers, we need to not just speak to the science and just say the science shows, the science shows. We need to speak to that risk that's perceived by the patients and the parents in front of you. And we need to respond to the challenges of making those communications about the risk without any perceived conflict of interest. So here's where we are, and then I'm going to switch. Vaccines are safe and effective. They are the social norm. We need to be communicating that. We need to understand specific reasons for why in the regions that you live, the communities that you live, that there are concerns about vaccine safety, because they can change from regions to regions. And we need to make sure that our messaging and our messages are on track and on task, because they matter. Remember that narratives are powerful tools to communicate, and I'll come back to that. Most patients do vaccinate, and we need to support this majority of patients and parents who vaccinate. And we need to make sure that we have ways to support all of you to engage in that conversation with your parents and with your patients. And we need to share those best practices of risk communication and conversations with each other. So that being said, I'm going to highlight the fact that narratives are powerful tools to communicate, and remind you of all of this is that storytelling is fundamental. So we need to propel our narrative of why vaccines are so important very, very strongly. So use your stories, because the other side are using stories too. And we need to remember that a story can be inaccurate and still change minds, and a story can be non-factual and still move people. And this is very difficult for folks like us, researchers, public health officials, medical professionals, to accept. This idea that a story can be wrong and change minds and move people is still very hard for us to accept, even with our current environmental and political environment. When you try to deny this by separating this is an authoritative source, this is a less credible content, a lot of times we get faced with skepticism. And you've heard this, right? The idea of fake news. So how do we address some of these vaccine common objectives? I'm going to spend the next 15 minutes or so just kind of talking about this. So believe it or not, providers actually have some vaccine hesitancy. And a lot of times it's because barriers are thrown up by providers simply because it's just easier to not talk about vaccinations than to figure out how to make the vaccination happen, right? And so I think this is something that it's on us. We got to recognize that ultimately it is an investment of time and effort by you all to make that vaccination happen. And that it is a requirement, it is necessary that you all address the 60% of the public that are vaccine acceptors, but just need to have a few of their questions addressed. By you addressing some of those questions, you can get them vaccinated. And it is an investment of your time to make that happen. And remember, just because a patient asks a question about a vaccine, it does not mean that that person does not want to be vaccinated or objectors to vaccination. They just might want to have a specific question addressed. And I think it's on us to provide that information. So just remember that we all have bias. We have these implicit biases providers that we want to remind ourselves that we have. Sometimes things like uncertainty of the disease leads to a lack of our confidence to recommend the vaccine. Sometimes our own personal perception of the risk of disease may impact whether or not we recommend that vaccine. If we don't see measles in our community, we might be less likely to kind of push measles vaccination. We sometimes make assumptions that the patient will not accept the cost of getting vaccinated. We sometimes make assumptions that the patient doesn't want it, that there's no demand, and that can be absolutely wrong. And sometimes we also don't understand the disease itself, or we misunderstand its epidemiology. For example, what I just said earlier, hey, measles is not common anymore, right? Which is obviously not how we protect our populations from measles. Sometimes we have liability fears, so make sure that you are aware that any vaccines recommended for a pediatric patient is covered by the Vaccine Injury Compensation Act. And sometimes providers can have irrational fears. We're all human. For example, I have heard, what happens if I spill a live vaccine, right? And then some folks, providers, and again, we're all human, may have logistic concerns about how I administer a vaccine. I can do injections. I just don't know how to do that oral route, right? Or I don't know how to do the intranasal route. So those are all legitimate concerns that we should be addressing, facing them, and saying, how do we do that, right? Learn, education, awareness. Ultimately, it's on us. We need to have an understanding of the risk and severity of the disease. We need to make a case for that disease, and we need to make a strong recommendation for the vaccine. Despite all our own personal biases, and we need to be able to do this. Because the ACIP and the CDC recommendations for vaccination, are best practices and our standards of care. So we need to adhere to those recommendations. What about the patients? I remind all of us and you that the number one reason why a patient gets vaccinated is because of your recommendation. And that recommendation you give has to be clear, it has to be concise, it has to be consistent. So I'm going to introduce to you several ways that you can think about how to start changing behavior in your patients so they become vaccine acceptors. This is the stepped approach to behavior change. It's a broader level approach where you first have to think about becoming a champion for vaccination for the patients you have in front of you. Gather your team, identify in your pharmacy what are the barriers and challenges that prevent you from vaccinating your patients when they come in. Establish solutions. So for example, can you use medications that you are filling to use that to identify your patients so that you can make an offer for vaccination? And then finally, step 5, how do you make that vaccination happen? How do you set up the operational flow of your practice so that you can easily give vaccinations, right? So that's something that the STEP approach will call for. It's a broad level approach to behavior change. Now I'm actually going to go down to more specific ways in which you can effectively communicate immunizations to your patients. So the ASK approach has been shown to be quite effective. I have a link on how to go to there. It's on the bottom there. It's the ASK standing for acknowledge, steer, and know. So acknowledge the patient's concern. This is the most important thing that you can do when you're talking to your patients about vaccinations. Acknowledge their concerns. Don't avoid it. Don't try to minimize it. Acknowledge it. Then, as you do that, you can then clarify what those concerns are, right? Then you steer the conversation, right? So if you see that there are myths in there, then try to refute that myths. But if your patient or your parent is not committed against vaccines, you can continue that conversation as you steer it to identify what else is getting in the way. And then finally, K for know your facts, be confident, be prepared. Recommend materials to the patient or the parent so that they can find out more information, and then be very clear and concise and confident with your professional recommendation to get vaccinated. The three A's: ask, acknowledge, advise. Very similar to what you've heard. You can begin to see a theme. Again, encourage the patient to ask questions. Again, this is the idea of listening, right? Listening to that patient. Acknowledge their concerns with respect and empathy, and then advise the parent to immunize. So you want to end the consultation with your patient or your parent with a mutually agreed upon action. So we're going to vaccinate today, or we're going to vaccinate Joey today, or we're going to make an appointment so that you can come back and get vaccinated, right? So something tangible that gets the patient back in again. I cannot emphasize how important it is to be listening to your patient and emphasizing. One of the stories I tell sometimes is this idea that I've given these talks many times in person. And one of the things I would ask my audience of healthcare providers is I'll give this analogy. You have a patient in front of you, and he tells you, I'm not going to get the flu vaccine today because my grandmother got the flu vaccine and she got flu from the vaccine. And she was, and I just don't want to get flu from the vaccine. And I say to you all, so what's the first thing you respond to the patient who's in front of you, who's now rejecting flu vaccine because his grandmother got it and got sick? And everyone, 95% of the crowd will put up their hands, and one of them will give an answer, and 95% of the answers will be, the first thing I will say was, well, you should know that you cannot get flu from the flu vaccine because it's an inactivated vaccine that only comprises dead virus or parts of the virus. Therefore, it's technically not possible to get flu from the flu vaccine. Think about that. Is that the right answer for this time and point? So I would say no. My first response to the patient would be, oh, I am so sorry to hear that your grandmother got sick. How is she doing? Right? So listening to the patient is extremely important. This is the case model. This is one that's been used a lot recently. Corroborate, again, you can hear it, right? Acknowledge the patient's concern, then find some point of agreement for a conversation. Case A stands for me, about me. Talk about what you've done to present your case as the expert here, right? What have you done to enhance your knowledge and your expertise? Talk also a little bit about the fact that you are a role model. You vaccinate all your children, or you vaccinate yourself against flu. The S stands for science. Tell them the science, the evidence of why the vaccine works and is safe and effective. And then explain and advise. Give your strong, confident recommendation again, based on the science and your example that you have discussed with them. So all of these focus in on this idea of principles of what we call motivational interviewing. And these are the principles of motivational interviewing, and they fall into this concept called RULE, R-U-L-E. RULE, the R stands for resist the writing reflex. So this is the idea that when someone comes up to you and says something that you vehemently disagree with because you know it's not based on evidence, the first thing we all try to do is to write it, to say, hey, no, that's wrong. That was not right. You're not based on science. You want to resist that writing reflex because otherwise you could switch that parent to like saying to a barrier, and that parent's commitment could actually move away from getting vaccinated. And then the U in RULE stands for understand. Understand the motivations behind why there is resistance to getting vaccinated. It could simply be, if you listen under the L, that patient today is just not feeling well and actually wants to get vaccinated and is looking to you for advice to when to come back to get vaccinated, right? And then the final, if you do that, is the E, you empower, right? Then you can say, with the example I just gave, if it's simply this idea that they're not feeling very good today, they're listening, you listen to that, and then you can empower the patient to say, it's actually okay if you just have a mild fever, I can still vaccinate you today, or we can set an appointment and you can come back. You've empowered the patient by thinking out loud through this process and deciding whether or not to get vaccinated today or some other day. That's a simple example that I just kind of walked through. But again, this is the principles of motivational interviewing. Resist that writing in reflex, understand the motivations behind the patient's decision, listen to the patient, right? And then empower the patient to do the next step, whether it be learning more or getting vaccinated. This is the Unity Consortium's 3Cs project. This is specifically focused for adolescents and HPV vaccination. There's a link to that website at the bottom that shows you what it is. But again, there's a lot of tools here to help you understand the principles of motivational interviewing because it was developed following the principles of motivational interviewing. Some resources for you to take a look at. We have a lot of good resources at the Immunization Action Coalition and at the summit that I co-chair. These are the websites that you can take a look at, and I hope you do. I really appreciate all of you, and I thank all of you for the hard work you do to get our patients vaccinated against vaccine-preventable diseases, to prevent outbreaks, and to prevent, obviously, the disease themselves. So thank you for your time, for your attention, and I hope that this presentation serves you well. I am now here.
Well, thank you very much for that overview. There was an enormous amount of useful information there, and it's really one of the most important issues right now, I think, in healthcare is this whole question, which brings up one question that I have, and that is there a difference in patients' responses to vaccines based upon that vaccine's relative target, saying COVID, as there's a lot of news about COVID vaccines right now, is there a different or going to be different sorts of responses to that than, say, standard childhood series, and that's where things seem to get really tense? Is there a difference in the way patients respond to it depending on what it's for?
Yeah, absolutely. I think it's interesting. COVID has actually revealed some things about how patients, especially adult patients, respond to this issue of vaccine confidence. Before COVID-19, I think if you talk about adult barriers that prevent adults from getting vaccinated, you hear a lot of patient factors that revolve around convenience. I was not aware that I was supposed to get the pneumococcal vaccination. My provider didn't talk to me about it, right? Those were the typical barriers we heard. Vaccine confidence was actually not one of those issues. COVID's turned that around a little bit. So with the COVID-19 vaccine process, because unfortunately part of the process was the transparency wasn't great, and as well there was a little bit of politicization around the process. One of the things we've been hearing from surveys of adults now is that vaccine concerns are now one of the reasons why someone would not get the COVID-19 vaccines. Concerns about side effects, adverse events, and remarkably, they align, very interestingly enough, with concerns that we hear all the time about flu vaccines. You know, there's one of the big ones is COVID-19 vaccine may give me COVID-19, which is like word for word, flu vaccine will give me the flu, right? So I think we need to do a really good job now of recognizing that there's a shift. You know, sometimes we're a little bit behind, and we need to recognize that shift. And I think we need to address that shift directly. And it is actually for those reasons, and I just want to put a plug here, CDC is about to launch a national initiative called the Vaccinate with Confidence Initiative. That initiative actually is based on some of the survey results that they've been getting regarding COVID-19 vaccine confidence and hesitancy. And it's actually a strategy that can not only just be used for COVID-19, but will probably be allowed to be used, can be used for all adult vaccines as well. And the three pillars, I'm not going to go through all of it, but just to let folks know, you can actually Google that when they start it. It's the first pillar is to reinforce trust. This is the idea of making sure that the public trusts the vaccine, in this case, obviously COVID-19, the vaccinators, you all, and the system that approved the vaccine. The second pillar to empower healthcare providers such as you all again, because again, this is ideas that if you're not confident in the vaccine, it's going to be really hard for you to be confident in your recommendation to the patient. So that's the second pillar. And then the third pillar is to engage the community, because we do know, obviously, with some of the issues with COVID-19 hesitancy, a lot of it exists in the minority communities. So we need to make sure we do that. So sorry for that long-winded answer, but I wanted to make sure I got that plug in for the CDC as well, because that's going to be a very interesting initiative that's about to launch. It's not launched yet, but Vaccinate with Confidence.
I'd like to then jump off the last thing you said there about minority communities and so forth. One of the things you emphasized throughout your presentation was empowering and engaging patients where they are, as opposed to trying to throw science at them and so forth. Can you talk a little bit about how that specifically can play out in minority and secondary communities?
Yeah, so I think it plays out as well in all communities, but in the minority communities, I think one of the biggest things that we've discovered is the fact that obviously you got to own the direction you want to proceed forward on. So part of empowering is giving that ownership, helping folks understand that indeed this vaccine has been vetted, it is safe, and indeed transparent in its process, that you are not a selected community that we're targeting, for example, to try the vaccine out on, right? Things like that kind of misinformation needs to be directly addressed. And unfortunately, we can't do it at this high level where we're all sitting here presenting. It has to be done, I would even argue, not at the state level. I think with some of these misinformation and addressing this, it has to be done at the community. So we're talking about addressing and educating and bringing in the community leadership, a trusted minister, a trusted teacher, a trusted local politician, someone who is in that community and has the respect of that community. We need to then engage that person to understand how complete and how clear the safety of the vaccine is in terms of the approval process, and answer all of that person's questions, so that there's no hesitation when they go out into their community, when they're going to be the trusted voice. They are not going to be hesitant. They're not going to say, you know, I really didn't quite trust what LJ said there. You know what I mean? We want to make sure that they say, I get it. I saw everything. I'm convinced I can sell this message, because that's what we need.
I appreciate that last really the conversation there. One of the things that the Connecticut COVID vaccine task force really worked on was bringing in those sorts of community leaders as part of those committees, especially the communications committee. And I think that is going to be very helpful in terms of engaging at the grassroots level when we finally actually have a vaccine in hand and can start distributing it.
And the healthcare providers are critical too. You all are essential. And if you have doubts about the vaccine, you need to go find out and clarify those doubts, because you are the number one reason why someone gets vaccinated. Pharmacists, healthcare providers. If you are doubtful and you don't give a strong recommendation, if you're kind of wishy-washy, you could do more harm than good. So it's on us as well to make sure that if we have questions, we get those questions addressed to our satisfaction.
To our audience members, please pop a question into the Q&A box there. We're happy to. We have a few more minutes of Dr. Tan's time here. We appreciate your time today. We know you're running from presentation to presentation today.
Today was a busy day. I think everyone wanted presentations on the 17th for some reason.
So while that's going on, maybe you could talk a little bit about the federal interplay with states on this issue, because I know that state by state law is a little bit different. For instance, Connecticut, we technically pharmacists can't vaccinate under 18 years of age, although that's probably going to change here pretty soon. How does that work, and what do you think are kind of best practices on that front?
Yeah, so that's a great question, and I don't have a good answer. It's federalism at its best, I think, and I think I'm not political, so I'm not going to shake that one a little bit. But I'll have to say, I think it's up to the states to decide what suits their populations the best, right? If you have a population that's having access problems to vaccines, I think then you need to figure out what's the best way to engage vaccinators. I think if you're a state that let's say with vaccines for children's programs, since you brought up the fact that some of it's about pediatric access, right? If you're in a state where you're having challenges getting vaccines for children's vaccines to the kids who are uninsured or underinsured, then I think it's imperative on the state's immunization coalitions, the state's public health officers, to decide how to engage pharmacists in a constructive way to participate, for example, in the Vaccines for Children program. So I think those decisions have to happen at the state level. I don't think we should. I think at the federal level we can obviously provide resources. We can talk about best practices and share them, as I've already mentioned on the presentation. But ultimately, the state has to decide what are the gaps in access and how do we address those gaps. And if it's about recruiting additional vaccinators and making legislation and or regulation accessible for them so that they can vaccinate, that's what the state has to do.
Excellent. We had a question come in here. How will they handle people, I assume this is about COVID, how will they handle people with antibodies needing the vaccine or not?
Great question. So actually, that is one of the primary objectives in the Pfizer clinical trial. I would argue it's probably also a primary objective in the Moderna vaccine clinical trials. One of that objective essentially is the effectiveness of the efficacy, because this is not an effectiveness study, the efficacy of the vaccine in people who have been previously infected with COVID-19. The data that comes out from that primary objective, so there were two primary objectives. The first was, what was the efficacy of the vaccine in people without previous infection? Then the second one is with and without previous infection. And obviously with the previous infection, they would have antibodies, and we would look and see whether the vaccine effectiveness or efficacy, was impacted by the fact that they had antibodies against COVID-19. I think this will be a temporal situation. I'm an immunologist by training. And so I would probably argue that obviously if we're 6 months down the initial infection and your antibodies have waned, there's going to be no impact whatsoever on uptake in terms of the vaccine being reacted to. But I think if you're closer to when you had your primary infection and you still have antibodies circulating, I think that would be an interesting question to see what happens to the vaccine. Because will the vaccine then actually boost, right? Or will the antibodies that are circulating impact negatively the take of the vaccine itself? So I think those are questions that the clinical trials are looking at. So great question. Thank you.
That's all going to be so much fun when this rolls out. It's going to be
exactly. It really will be
very, very interesting to see how all this happens. Question from Steve Costanzo. I believe Rhode Island just decreased age of vaccinations for pharmacists at 12 years old. Where is CT in this process? Go ahead. I have an answer too, but
I can't answer that one. That's going to be on you all.
Well, I can tell you this: that conversation is in place, and there's some. It's basically trying to get the DPH and Department of Consumer Protection, which actually oversees pharmacy in the state, on the same page and on the same electronic platforms. That's basically the key problem right now, is getting pharmacists into the vaccine for children system and how to track that as it goes forward. So hopefully in the not too far distant future, we'll have those technical issues worked out, because I don't think it's a question of motivation or desire anymore. It's literally one of the computer systems don't talk to each other. And getting that to work appropriately is the next step. If not, so what should be our big takeaway today, Dr. Tan? What should be the thing that, when people go back to their clinics or their pharmacies, that is at the front of their mind the next time a patient comes in asking about immunization?
Yeah, so I think the big takeaway again is that firstly, I think you need to recognize that when someone questions a vaccine, I don't think it's necessarily because they are anti-vaccine. Sometimes we bristle right away, so don't bristle right away. And again, ask, listen, and follow up. And I think that's the best thing we can do. And in order to do that, I think we're not saying that you have to be the God on everything that's knowable about vaccines, but we do have to have some confidence in the way we give a recommendation and the science that's behind that recommendation. So with COVID-19 coming up, I think one of the best things we can suggest is to ensure that we stay up to date with the clinical trials and with the mRNA vaccines that are coming out, specifically to their safety, because I think that's what we're hearing a lot of concerns about.
Actually, that was the last question just came in. Should we be 100% confident in the accelerated warp speed process? And if so, I think you just mentioned that the focus on safety is very important here, right?
Yeah, absolutely. And it's funny, the presentation I just gave today, and I don't know how many of you are with the American Society for Health System Pharmacists. but I recorded a presentation that's going to air in December. So I'm going to give a plug for the ASHP here. And that presentation was entirely about the clinical trial process for the Moderna and Pfizer vaccines in terms of approval. And I actually do talk about how the pandemic vaccine trials were, while they were accelerated, they did not compromise safety or efficacy studies. The one thing I always say when we talk about that is to be very cognizant of the limitations of that, obviously, right? One of the reasons why our traditional vaccine trials take 4, 5, 6, 8, 10 years and longer is because we do have that 4 or 5 years of a follow-up with regards to vaccinations. We don't actually license the vaccine until we've had several years of follow-up data in terms of safety. The one thing we are not going to be so worried about, not going to have a lot of data on, is obviously the long-term impact safety data with these vaccines, because obviously we don't have that same extended follow-up. But that being said, I think I want everyone to know that no shortcuts were taken. And secondly, just because they're mRNA vaccines and they've not been used for a licensed vaccine, the knowledge base behind mRNA vaccines is extremely significant. It's been used to create vaccines before, just none that's been licensed. And there has been a lot of explosion in the science of mRNA vaccines in terms of stability, in terms of delivering the mRNA, in terms of how quickly they break down in the body after stimulating the immune response. So I think one of the things we can reassure ourselves about is that the two vaccines that are coming out from Moderna and Pfizer based on mRNA technology has science behind it to suggest effectiveness as well as safety. So I think I can leave with that.
Yeah, I mean, that actually answers the last question we had up here is, how broad can we expect these mRNA vaccines to be? And
I think we won't know the answer until we know the answer. But I think, again, so one thing to keep in mind is that the Moderna and Pfizer, and I don't want to go into shop talk here, but while he talks about ACE receptors, I can see the question here. I think it's important to remember that the point mutations that we've been seeing in the coronavirus has not been very specific to key receptor amino acids. And the reason for this is obvious, right? If a virus mutates its binding protein to the point where it can no longer bind the receptor to enter a cell, it can no longer reproduce. So there is very strong preservation or conservation with specific key amino acid residues. And so far what we're seeing, again, knock on wood, is that the vaccine does not appear to be losing its immunogenicity because of these point mutations that are being picked up by the SARS-CoV-2 virus right now.
Excellent. Well, Dr. Tan, thank you so much for your time today. We really appreciate it. I think this has been an incredibly informative and helpful program. And just want to thank, on behalf of all our attendees here today, thank you very, very much for your time.
Pleasure to be here, and thank you for the opportunity.
Thank you. So the code for this program is the word safety, SAFETY.